Hallux Valgus correction with a TMT-1 instability by Dr. Micha Hoyer, Stuttgart, Germany. Diagnosis: a 54-year-old woman with a TMT-1 instability of the left foot, Hallux Valgus angle of 39 degrees, and an intermetatarsal angle of 16 degrees. In this case, a lateral release is performed first, followed by a TMT-1 fusion with a Medartis 2.8 Trilock TMT-1 fusion plantar plate and an Akin Osteotomy on the proximal phalanx with an all-in-one staple. The patient is positioned on her back with a femoral tourniquet. Approach: TMT-1 instability can easily be seen in this patient. We start with the correction of the Hallux Valgus angle. A 2 cm incision over the MTP joint is needed. A Y-shaped cut of the capsule is performed, allowing for a better adjustment of the excess capsule at the end. In cases where there is a contraction of the lateral soft tissue, a release of the lateral capsule and the lateral ligament is done with a Montgomery elevator. The pseudoexotosis on the medial side of the metatarsal is removed with a saw blade. Joint preparation, TMT-1 joint. A 4 cm medial plantar incision is performed slightly above the TMT joint. With further access, pay attention to the tibialis anterior tendon. The capsule is then opened to prepare the TMT-1 joint. The first cut is made at a 90-degree angle to the metatarsal's long axis. Take care to only resect cartilage and not too much bone to avoid shortening of the metatarsal. Before you make the second incision, it is recommended that you first reduce the intermetatarsal angle with your thumb. The second cut is then made parallel to the first cut. Be sure to remove all cartilage to allow for good fusion. Prepare the bone in the joint surface with multiple drill holes to aid in fusion of the joint. Close the intermetatarsal angle by internally rotating the metatarsal bone and applying medial pressure to the metatarsal 1 head with your thumb. Fix the TMT joint with 2 K-wires and check the position with an X-ray. Plate fixation. Apply for the 2.8 Trilock TMT-1 fusion plate. The plate should be positioned strictly plantar. The position of the plate is determined by the tibialis anterior tendon insertion. Feel free to use the self-holding drill sleeve to hold the plate onto the bone. Drill in the first of the 3 distal plate holes, aiming in a proximal dorsal direction into the medial cuneiform. Measure the length of the screw and insert a cortical screw. Drill the last proximal plate hole, measure the length, and insert a second cortical screw to attach the plate to the anatomy of the bone. Perform an intraoperative X-ray to control and check for correct plate positioning. In this case, the cortical screw can be slightly tightened further. Then insert locking screws into the remaining distal and proximal plate holes. The K-wires are then removed, and the stability is checked manually. Perform an X-ray control. Akin Osteotomy. To further correct the Hallux Valgus angle, an Akin osteotomy is performed. The incision is extended distally, and the proximal phalanx is exposed with two Homan hooks. A basic medial wedge osteotomy is performed with an oscillating saw, leaving the lateral cortex intact. Close the osteotomy and apply the target template from the all-in-one staple. Drill the holes for the legs of the staple with the enclosed K-wires. After X-ray control, remove the K-wires and hammer in the staple. Make a final X-ray control. Wound closure. First, the medial joint capsule is closed, and the excess of the capsule is removed with a scalpel. The subcutaneous wound is then closed at the proximal incision, and the skin is sutured. A sterile bandage and an elastocompressive dressing wrap are then applied. Finally, the tourniquet is released. Post-operative care. Pain-limited, full weight bearing with a post-op shoe for 6 weeks. Physiotherapy is recommended after wound healing. 6 weeks post-operative X-ray. Radiographs 6 weeks post-operatively show a well-aligned and fused TMT joint and stable fixation of the Akin osteotomy.